Good morning. Let's go ahead and get started with Chapter 1, Mental Health and Mental Illness. And again, if you have any questions on anything we cover today, feel free, shoot me a quick email. I'll get back to you quick. If you're studying, just looking for a quick answer, shoot me a text. If we aren't able to get you up to speed that way, I'm always happy to set up a Zoom call, quick phone call, whatever works for you. Make sure we're keeping up. There are a lot of negative connotations when you hear terms such as mental health and mental illness. In its broadest sense, mental health is just that individual's ability to cope with the normal stresses and challenges of life. And everyone will fall somewhere between those two varying extremes of perfect mental health and extreme mental illness. It's how you deal with those stresses and challenges of life and able to function with them. That's a subject you'll hear come up a lot in those group therapy within psychiatric hospitals, is helping the patients to deal with that stress, to get rid of those intrusive thoughts and be able to function productively within society. There are many traits of mental health, everything from the capacity for rational thinking and being able to logically analyze the world around you, to communication skills, learning, resilience again, with that ability to effectively deal with the stresses and challenges of everyday life, and also self-esteem, especially in a lot of your severely depressed and anxious patients. They'll often have an extremely low sense of self-worth, having a negative impact on their life. On the opposite side of mental health is mental illness. And this is a term with a lot of negative connotations. And it's also a term with a lot of varying degrees of severity. In its broadest sense, these are psychiatric disorders with definable diagnoses in what's called the DSM-5, the big manual of psychiatric disorders. And these are disorders that are having a negative, significant impact on the patient's daily life and being able to function in society. And there's lots of different forms of dysfunction, everything from developmental disorders, biological and brain chemical imbalances, physiological disturbances based on past traumas, stress, anxiety. And often the treatment of these disorders is going to be culturally defined. And by that we mean there's some cultures that are going to be very open to talking about their problems, telling you what's going on, and very receptive to treatment. Or on the other side, there will be a lot of other cultures who are very closed off, much more hesitant to tell you what's going on, and they're going to be much more resistant and reluctant to work with you. For our first case study in this module, Mrs. M comes to the clinic reporting a feeling of hopelessness. She works full-time and is dealing with a troubled teenage son and her elderly parents. She confides in you that she can't deal with life right now. Discuss attributes you might screen for to quickly assess her overall mental health. And right away, when you see a statement like, I can't deal with life right now, your priority as a nurse is going to identify, is she a danger to herself or others? Are you feeling suicidal? Do you have any ideation, any thoughts of harming yourself? Any thoughts of harming your son, your elderly parents? And that's going to be automatically your top priority, especially when you start getting into these ATI questions, your NCLEX questions. Any patient that is a danger to themselves or others is going to be your top priority. Also, if you have a suicidal patient, when it comes to NCLEX, that patient is always a one-to-one. I know many of you are probably working in the hospital setting right now. And yeah, you probably know from working that it's next to impossible to get a sitter or a one-to-one. I shouldn't say next to impossible, but it can be very, very difficult, especially with how short-staffed some places are. Keep in mind, when it comes to these ATI, NCLEX, these standard nursing questions, you have every resource in the world. If this patient is even a hint of a danger to themselves or others, our patient safety is going to be top priority. You're going to be reporting any reports of suicidal ideation to the provider. They can look into pink slips and voluntary holds. And also simple things such as hook points, any weapons, anything the patient could possibly use to harm themselves. You need to be focused on removing. Again, because as we discussed, no one is completely mentally healthy, just as no one is completely mentally ill. Everyone falls somewhere in the middle on that spectrum here. And everything like stress, pain, family issues, just dealing with everyday life can have a dramatic impact on where someone falls within that spectrum. Got to keep in mind, some patients are much more resilient, much more able to handle stress, and have a major traumatic event not move them from one end to the other so much. As for another person, a major traumatic event could very well push them much further into mental illness. This is a reason we talk about within the mental health on a mental health unit on the floors. These patients are going to do group therapy, and one of their big things they always learn and talk about is coping skills and ways to manage and deal with that stress. All right, let's talk about risk and protective factors. Because again, maintaining that patient safety is always going to be your top priority on the unit. Identifying those dangers to the patient, removing any possible weapons, hook points, anything that could pose a danger to both that patient, the other patients on the unit, as well as yourself. All right, the first attribute and behavior we're going to talk about is resilience. Some patients are much more resilient than others. They've been taking care of themselves much longer. They're able to deal with problems. They know how to cope. They're able to manage their everyday life with very, very little help. Whereas other people have been reliant on others for much of their life. And they're going to need much, much more help to function within society. A lot of other factors goes into the stress of everyday life. Family problems, dealing with family issues, drama, tensions can be extremely difficult for some people, both based on their own personal attributes as well as dysfunction within their own families. Things like schoolwork, as you in nursing school know, there's a lot of extra stress that goes into nursing school. Socioeconomics, people are struggling right now. Inflation, cost of everything is going up, and people are really struggling, and that can put a lot of extra stress on there, especially when you start factoring in the cost of schools, the cost of raising a family, and working to mitigate all of these factors. Our current political climate, no doubt, plays a major role in people's mental state as well. To say that things are polarized and dramatic in this country would be an understatement. I mean, things are probably as tense as they've ever been for any of our lifetimes. And unfortunately, things do not look to be improving anytime soon. And helping your patient with coping skills, managing that stress, identifying these problems before they can continue to grow and multiply. The perceptions of mental health and mental illness also plays a major key factor in patients receiving treatment. Unfortunately, mental health treatment has a very negative stigma. Patients are very reluctant to talk about both psychiatric medications, receiving treatment, the psychiatric problems that they're dealing with, and instead of seeking treatment, they try to hide that. And it can be a very major impediment to making progress with that patient. Unfortunately, the root of most mental disorders is genetic. A lot of people are very predisposed to these conditions. Everything from anxiety, how they deal with stress, depression, everything into schizophrenia, bipolar. There's a lot of these have a very major genetic component. And just like any other genetic disease, it's out of their control. And unfortunately, a patient receives treatment for cancer does not have the same stigma as a patient receiving treatment for mental illness. Another thing to consider is that nature versus nurture, that diathesis stress model. How much of your upbringing is from genetics and how much is that your environment? And that's been a debate going back for a long, long time, that nature versus nurture. I'm of the opinion that it's a combination of the two. You've got your genetic base. There are things that you are predisposed to. But there is also a very major influence from your environment as well. Diathesis means biological predisposition. This is what you are genetically predisposed to. These are your major risks, just from your genetic makeup. Then you've got your stress, that environmental stress, that trauma, that socioeconomic factors, family problems, every additional stress, upbringing, childhood traumas. They all combine together to make you who you are. And the most accepted explanation for mental illness falls right here, in that it is a combination of both genetic vulnerability and the negative environmental stressors. Let's talk social influences on mental health care. There are a lot of new resources out in the community springing up all the time. I don't know about Texas, but here in Ohio, that opioid epidemic hit us severely hard. And there are a lot of recovery houses coming up around our area. There's also a lot of organizations such as NAMI, the National Alliance of Mental Illness. That's a great organization, does a lot of good work, and it's been around for a long time. Other ones include Decade of the Brain, the Human Genome Project, President's New Freedom Commission on Mental Health, the Institute of Medicine, and the Research Domain Criteria Initiative. And that's just to name a few. There is a lot of resources that these patients can call upon to receive treatment, to receive help outside in the community, outside of inpatient psychiatric care. Continuing on with our case study, we discover Mrs. M has a history of major depressive disorder. Do we have to deal with that, she says? Can't we just focus on my insomnia? If I could just get something to help me sleep at night, I think I'd cope better right away. Besides, insomnia would be covered by my health insurance. It's an uphill battle getting compensated for any treatment for the other. Fighting with insurance people is not going to help with anything. And she brings up some major points. These are very common issues. Insomnia related to anxiety and depression is very common. And she just wants a sleeping pill, something to help her sleep that she feels like would improve that. But unfortunately, that's just going to be more masking the issue as opposed to treating the underlying causes and helping her get a healthy, natural night of sleep. She also brings up another point of the issue of getting funding, getting insurance to pay for mental health care. Even getting physical illnesses or physical injuries treated with health insurance can be difficult. It's even much more difficult when we start talking about psychiatric disorders, which can be very easy for the health insurance company to dismiss as not necessary. There has been a lot of progress made on helping these patients get funding and coverage for mental health care. Everything from the Mental Health Parity Act, parity meaning equivalence, required insurance companies to provide equal treatment coverage for psychiatric disorders. This was further expanded upon with the Patient Protection and Affordable Care Act. Coverage for most uninsured Americans through Medicaid was expanded. This created healthcare insurance exchanges for more choices, insurance mandates for coverage, and these came a long way in helping these patients receive funding so that they can receive the mental health treatment that they need. Let's talk about the epidemiology of mental disorders. And a lot of these are terms you're probably very familiar with just from the COVID pandemic. Terms like incidence, this is the number of new cases in a given time period, versus prevalence, this is the number of cases regardless of when they began. And lifetime risk, this is the risk that one will develop a disease in the course of their lifetime. As we've already touched on, there's some patients that are much more genetically predisposed to developing that condition. There's also societal and stress factors that greatly increase the likelihood that they will develop one of those issues. And the study of this distribution of mental disorders, identifying these high-risk groups, identifying these risk factors is a key part of helping to allocate funding, identifying high-risk areas and groups of people. From a public health perspective, when we're trying to identify groups needed for treatment of specific mental disorders, we're looking for things like natural history of the illness, diagnostic screening tests, the necessary interventions that we could use to have the greatest amount of good for the greatest amount of people. And these results are used to describe the frequency of mental disorders, symptoms appearing together. Unfortunately, a lot of the mental conditions, the mental disorders out there in society are completely untreated, are completely undiagnosed. And anything we can do from a mental health perspective, from a public health perspective, to both increase awareness of this, but also to encourage these patients to receive treatment, could have a profoundly positive impact on their lives. An audience response question. One of Mrs. M's complaints is about insurance. Which of the following does the Mental Health Parity Act provide? Coverage for most uninsured Americans through expanded Medicaid eligibility? Health insurance exchanges? Insurance mandate for coverages? Or equal coverage for mental health care? And A, B, and C, those were part of the Affordable Care Act, whereas D, that was specifically part of the original Mental Health Parity Act, requiring those insurance providers to provide coverage for mental health at the same level that they would for any other physical illness or injury. As we talked about earlier, the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. And keep in mind, we may be due for the 6th edition within the next year or two now. This is the manual of every possible psychiatric condition and disorder you could ever think of, including common treatments, definitions, and anything you could possibly want to know. Every possible mental disorder you could think of is included in this manual. It's the official medical guideline of the American Psychiatric Association, And it's based on specific criteria and influenced by multi-professional clinical field trials. I used to have a PDF version of this. I used to post on the class. Let me look around some old hard drives. If I can find this PDF version, I'll post it up on the Blackboard for you as well. Hopefully I'm not hitting copyright too hard with that. I don't believe I am. And then in the same vein, we also have the ICD-10. Many of you working right now as LPNs are probably very familiar with the ICD-10. And just like we talked about with the DSM-5, categorizing every possible psychiatric illness, ICD-10 is used primarily with funding, Medicaid, insurance, and this provides a code for every possible condition, both psychiatric and physical, you could think of. It's clinical descriptions of mental and behavior disorders, 2 broad classifications, subclassifications, and I mean, if you can think of it, it's going to be covered in here. They have a way to bill you for it. Now, you may be thinking, where do you as the nurse fall into this mental health treatment plan? As the psychiatric mental health nurse, you are promoting mental health through assessment, diagnosis, treatment of both behavior and mental disorders. You may be helping to treat them with both physical disorders as well as their mental health issues. I started out in mental health nursing at a hospital called Laurelwood here in Cleveland, up on the east side. It's a very old hospital, been there a long while. And primarily I worked down on what was called the dual diagnosis unit. And these were patients with both severe mental health issues, but also coinciding with severe substance issues. So they're both detoxing from alcohol, detoxing from opioids, at the same time as we're getting them back on medication, treating them for their bipolar, for their schizophrenia. I'd also float up and work a lot with the pediatric patients upstairs. We had some of the only major pediatric mental health units in the area. And the unique needs and requirements of what the adult patient required versus what the pediatric patient required was pretty dramatic. We talked about that diathesis stress model. For those adult patients, it's going to be both genetic and environmental factors. That schizophrenia tends to manifest late teens, early 20s, and they're then medicating themselves out with illicit drug use. Versus those pediatric patients, yes, there is mental health conditions manifesting at that age, but their problems also stemmed a lot from environment. They're much more susceptible to those traumas and severe issues just from a poor upbringing and environment. And finding the unique needs that each of those patient needs to provide effective treatment can take a lot of skill, take a fine touch. Every nursing student's favorite topic, nursing diagnoses, and the classification of nursing diagnoses. And for us, this comes from the International Classification for Nursing Practice, the ICNP. It's developed by the International Council of Nurses and provides standardized nursing diagnoses. And this helps everyone both across the country and worldwide to have standardized definitions of these disorders and conditions to help standardize treatment across the board. There's many different levels of psychiatric mental health nursing. I started as an ADN, associate degree nurse, started as a paramedic, got my associate degree in nursing, and my first nursing jobs were working in mental health and psychiatric nursing back at that hospital we talked about, Laurelwood. We know what that RN degree is, that undergraduate ADN. Moving on to your BSN, there's a million options. We know what the requirements are. You're currently working towards it. And moving forward, it's the great thing about nursing is that there is 10 million different options for growth within specialties. Those of you looking to move on to be a nurse practitioner, that psychiatric nurse practitioner is still greatly in demand. There's some of those nurse practitioner specialties are very saturated. It can be very difficult to get that first NP job. Versus psychiatric nurse practitioner, they are still greatly in demand. I know a lot of psych nurse practitioners, both that I used to work with, both that I've hired in working as clinical instructors, and that psych nurse MP is still, they're greatly sought after. There's a lot of opportunities if mental health is your passion, something you're looking to advance further in the future. Trends affecting the future. Everything from the educational challenges, getting through nursing school can be tough across the country. Those standards are very high, but for a very good reason. Nursing is a tough job, and we're training you to meet that standard. There's also that demand for mental health professionals. The nursing shortage, again, is across the country. And that's especially true for mental health nursing. It is a very unique skill set. What would make someone a great bedside nurse in the hospital is not necessarily the same skills that would make for them be a great psych nurse, and vice versa. It's a very unique skill set. One issue we used to have with pediatric nursing and pediatric psych nursing was a lot of nurses would use it to get that pediatric experience so they could then move on to that pediatric NICU jobs, working pediatric in the hospitals. And the skill set that made for a great NICU nurse for those little teeny tiny preemies was not necessarily the same skill set that they needed for pediatric inpatient psychiatric care. Other things like the aging population. The baby boomers are coming at that age where they're both retiring out of the profession, as well as what happens as you age. Increased medical care, and that includes increased psychiatric care. How many people you think are out there have been dealing with mental health issues and managing them themselves their whole life, and as they get older, as the dementia starts setting in just a little bit, those psychiatric issues can greatly manifest. Another one you see a lot is alcoholism in that elderly population. I could tell you about a lot of guys who their whole lives they go to work all day and then they come home on Saturday and they crack a beer. Suddenly they retire, and the only way they know how to spend their time is sitting in the backyard cracking a beer, and that can have massive issues on a patient. That retirement age, suddenly they've got nothing but free time, and suddenly their alcoholism has greatly increased. It's also a wildly changing specialty. Science, technology, electronic healthcare, managing all those psychiatric healthcare records, advocacy. We talked about the legislative changes where mental health care is making great strides as a specialty, making great strides as a profession. But it still has a long way to go before it's treated on the same level. And again, that's all we've got for you for Chapter 1. I'll see you next here in Chapter 2. Again, if you have any questions on anything we talked about, hey, shoot me an email, give me a text, give me a call. I'm happy to go into anything with greater detail or answer any questions you have.